Okay, guys, this is your skin and wound lecture, chapter 35 in your book. Skin is part of the body that many of us take for granted. It's a complex and vital organ. The skin is the largest organ of the body, weighs more than 6 pounds, has multiple important functions that are essential for overall health. Some of these functions are your thermal regulation, allowing the ability to dilate and constrict blood vessels, which allows for the heat to release or retain from the body. The skin has a major role in your sensation, giving tactile feedback from surrounding environments. The sensitivity of the skin as a sensory organ allows us to feel something as personal as touch of a loved one and identify objects without the aid of sight. The skin alerts us to potential danger through its ability to transmit the sensations of pressure, pain, and temperature extremes. It's involved in the production of vitamin D in the presence of sunlight. It works to rid the body of waste products, and it's essential in your fluid and electrolyte regulation. The skin serves as an effective barrier to environmental hazards, such as ultraviolet light, chemicals, and it prevents them from entering the body. The skin's normal acidic pH provides protective mechanisms against pathogens. In addition to its physiological functions, the skin is part of each person's self-perception, and that's what connects us to our personal and even sometimes our cultural identity, our body image, and our self-expression. So these are the learning objectives that are defined within your textbook. These are common terms that you might want to familiarize yourself with. Some of them will only be in this lecture, so if you don't pick up on them, you might need to use your Tabler's dictionary to further understand them. So we're going to start with the structure of the skin, right? The first layer is the epidermis layer. This is the outer portion of the skin, and it's the thinnest layer. It has the ability to regenerate every 4 to 6 weeks. The epidermis can be divided into 5 more layers. The outermost layer is the stratum corneum. This is comprised of numerous thickness of dead cells functioning as a barrier. It restricts our water loss and prevents fluids from leaving. And it stops things like additional fluids, pathogens, antigens, and chemicals from entering in your body. The innermost layer is the stratum germinatum. This is a single layer that is continually reproducing cells, pushing the older cells towards the surface. Other things found in the epidermis are your keratin, and this is a protein that contains cells that give this strength and flexibility and allows the skin to repair itself. We have melanocytes, which produce melanin, which is your pigment that gives the skin the color and provides protection from ultraviolet light. And then there's Langerhans cells. These are mobile, and their function is to phagocytize or engulf foreign material and trigger an immune response. After that, we have our dermal layer. So your dermis lies below the epidermis and above the subcutaneous tissue. It's made of irregular fibrinous connective tissue that provides strength and elasticity to the skin and is generously supplied with blood from blood vessels. Within the dermis are sweat glands, sebaceous glands, wax glands, hair and nail follicles. Your sensory receptors lie here, as well as elastin and collagen. The next layer we have is our subcutaneous tissue. This is composed primarily of connective and adipose, so your fat. It provides insulation, protection, and a reserve of calorie in the event of severe malnutrition. This layer varies in thickness depending on the body site location. It can also change due to sex hormones, genetics, age, and nutrition. It's also distribution of those subcutaneous tissues. It's important to know and understand these layers because they'll help us understand healing and treatment. And this slide is just a different visual representation of the skin. It's a little bit more clear, blown up. So next we have factors that affect our skin integrity, right? So we're going to start talking about wounds, and wounds are a disruption that occurs in the skin's integrity. And this leads to loss of the skin's normal function. Many different factors can affect the body's ability to maintain intact, healthy skin. So what factor that affects our ability to maintain skin integrity is age. As we age, it's more likely that we're going to have comorbidities. So comorbidities like diabetes, cardiovascular disease, those make us take medication, and those medications can affect our skin, and we can have damage to the skin that occurs over time with our age because of repetitive light exposure. And then aging also dramatically affects the appearance and function of the skin, because as we age, we have a thinning of our epidermis or dermis and sometimes our subcutaneous layers. This results in a reduction in our elastin, our collagen fibers, our sweat glands, and our sebaceous glands. These changes will lead to sagging and wrinkling of our skin. Our skin becomes dry. It can have a paper thin appearance, and we often see this in our elderly patients. It contributes to a reduction in the skin's ability to serve as both an insulation and a cushion, thereby increasing the vulnerability to have trauma and temperature extremes. We also have a reduction in our melanocytes after the age of 40. This leads to the graying of our hair and our increased susceptibility to develop skin cancers. With the decrease in the number of Langerhans cells with aging, we have a corresponding decrease which occurs in the resistance to infection. And then another factor that can affect our skin's integrity would be our mobility. We know that prolonged bed rest and the inability to move can increase pressure, shearing, and friction, and all of those can lead to breakdown. Other things that can affect our skin's integrity is our nutrition and our hydration. So when we talk about healthy skin depends on adequate nutrition and hydration to make it good. Adequate protein levels maintain the skin, repair minor defects, and preserve intravascular volume. Vitamin C, zinc, and copper are involved in collagen formation, and deficiencies of either of those can impair your healing. Both very dry, dehydrated, as well as edematous, which would be overhydrated skin, are prone to injury, especially when exposed to pressure, shearing, friction, and moisture. Patients with impaired cognition, such as Alzheimer's disease, dementia, altered level of consciousness, are not they're at a higher risk for a pressure ulcer because they're not aware of the need to reposition, just like the patients who have a diminished sensation. They're less able to sense a hot surface and would likely suffer a burn, or they could have a cut or a wound to an area with limited sensation, and this may go unnoticed and therefore untreated. So they are also and they're also unable to feel the pressure in an affected area. So again, they're not going to be changing positions to relieve that pressure, which would increase the risk of having skin breakdown. Impaired circulation restricts activity and produces pain and leads to muscle atrophy and development of thin tissue that's prone to ischemia and necrosis. Impaired venous circulation can result in engorged tissues with high levels of metabolic waste that are prone to edema, ulceration, and breakdown. Both forms of circulation impairment delay wound healing. In fact, circulatory impairment is one of the main causes of your chronic wounds. And then medications. Multiple medications can cause pruritus, which is itching, or dermatosis, which is a rash. It can increase photosensitivity, alopecia, so the loss of the hair. So without the hair, you're not having that extra layer of protection over the epidermis. Or we can have pigmentation changes that can result in changes that impair skin integrity and delay healing as well. Again, we talk about moisture. Moisture leads to maceration. Maceration is a softening of the skin, and it increases the likelihood of skin breakdown. And then fever. So fever, first, it leads to sweating, which can cause maceration. And then second, it increases the metabolic rate, which thereby rises the tissue demand for oxygen. And that increased demand of oxygen is difficult to meet if there's any circulatory impairment or tissue compromise secondary to pressure and pressure. So next we have infection. Infection implies to microorganisms that are causing harm to the skin by releasing toxins. These are going to be invading your body tissue and increasing your metabolic demand on your tissue. And then our lifestyle choices. So tanning, which exposes the skin to increased ultraviolet rays, which increase your risk for cancer. Bathing, which again can cause too hot or over drying soaps. Both of those can lead to the removal of the oils that protect our skin, or if you become too moist, you can have that maceration again. And then body piercings and tattoos, which places at a risk for infection and scarring. And then the final one is the medical adhesive related injuries. These occur when superficial layers of the skin are removed by medical adhesive, and which the erythema and or other manifestations of skin trauma or reaction, including formation of vesicles, skin erosion, epidermal tears. This will persist more than 30 minutes after the removal of the adhesive. It causes pain and puts them at an increased risk of infection, and they can potentially have an increase in wound size from this and delayed healing. So our classifications of wounds. There's many ways to classify wounds, and they can be labeled according to their underlying cause. For example, the term diabetic ulcer, arterial ulcer, pressure injury are all used to describe wounds. The same wounds can be classified more broadly by basic description of the integrity of the skin and can be referred to either as open or closed. Wounds can be classified specifically towards their depth and if there's a presence of infection or contamination, or the length that it time for it to heal. So a chronic wound or an acute wound. For nurses, it's important to understand what these terms mean and what to see where they're overlapped to better communicate with the patients and with other healthcare members. So we're going to look over the difference. So an open wound is characterized by an actual break in the skin surface. For an example, an abrasion, a puncture, or surgical incisions. These are all types of wounds. Some are chronic, like those seen from a pressure or a vascular disease, but they're all open. And then we have closed wounds. So predominantly closed wounds are seen with bruising. The skin's still intact. Any wound that's open puts the patient at a greater risk for infection from outside organisms. A closed wound does not necessarily indicate a more benign condition. And we know that some injuries first occur below the level of the skin, such as a pressure ulcer or a fractured bone. And then the integrity of the skin is not a good indicator of the severity. And we'll talk about that more when we get to our pressure ulcers. So next we have our wound depth. Okay. Your wound depth is superficial, partial thickness, or full thickness. When we talk about superficial, superficial only involves that epidermis. And then the partial thickness involves the epidermis and the dermis, but it does not extend through the dermis to the subcutaneous layers. These wounds tend to heal quicker. They really leave no scars unless the outside factors delay the normal process of healing, which we'll talk about that in a little bit. We have our deeper wounds, and a deeper wound is a full thickness wound. This extends through the dermis to the subcutaneous layer, and these can extend further into muscle, bone, or underlying structures. Full thickness wounds tend to heal slowly, they leave scars, and they're more likely to become chronic in nature. So if we read something that says that a wound extends to the bone, it's going to be a full thickness. However, when we start to talk about pressure ulcer grading, you have two different pressure ulcers that are considered full thickness. And you need to know that one of them includes to the bone and one of them does not. And again, we'll go over that more in a little bit. So amount of contamination. What's the difference, right? So a clean wound is one in which there's no infection and really no risk to develop an infection, or the risk is extremely low. An example of this would be a closed surgical incision made in a controlled, sterile environment of an operating room, and it did not involve bacterial containing organ systems. This would be considered a clean wound. A clean contaminated wound is similar to a clean wound, but because the surgery involves an organ system that is greater to contain a bacteria, the risk for the infection is greater. So say we had to cut into somebody's bowel, right? We know that the bowel's filled with plenty of bacterial containing things. So that would be a clean contaminated wound. A contaminated wound results as a break and sterile technique during surgery. So we had a perforation of an organ. So the doctor accidentally nicked the colon, the small bowel, the appendix, or the appendix exploded before we could take it out. So this would allow for spillage of bacteria in laden material into the wound, or from certain types of trauma or accidents, such as a penetrating trauma. These wounds are a higher risk for infection than a clean contaminated wound. And then we have an infected wound. So an infected wound shows clinical signs of infection, including redness, warmth, increased drainage, that may or may not be purulent. And when we talk about purulent drainage, which we're talking about that it contains pus, and it has bacterial count in the tissue when the tissue is cultured. And then we have a colonized wound. So a colonized wound has one or more organisms that are present on the surface when we do a wound swab, but there's no overt sign of an infection of the tissue or below the surface. So colonization is very common in your chronic wounds, and they think that this is what's contributing to the body not being able to heal it and what's delaying it. We can also, when we start talking about colonized wounds, we can kind of start to talk about our drug-resistant infections. And these are going to be an infection on your wound from something like a Staphylococcus aureus that's now become methicillin resistance, and that would be your MRSA. So these microorganisms or bacteria are infected, and they're very difficult to treat because they're kind of those super bugs that you hear about. And then we have a chronic and acute. So acute wound follows the expected and predictable rate of healing. It has no complications to the healing, and it typically takes 1 to 4 weeks. Then we have a chronic wound. It starts as an acute wound, but it does not follow the expected healing process. And we're going to talk about the standard healing process in the next few slides. So healing, right? As wound progresses through the phases of wound healing, If it's uncomplicated, it would be an acute wounds. Wounds such as surgical incisions, traumatic wounds, things which our edges can be approximated, which means brought together to heal, are examples of an acute wound. This wound is said to heal by primary intention. Wounds that heal by primary intention tend to heal quickly and result in minimal scar formation. By contrast, chronic wound fails to progress to healing in a timely manner, often remaining open for an extended period of time. Chronic wounds commonly heal by secondary intention, and this is when a wound heals by new tissue that must fill in from the bottom of the wound up through the wound bed to the top surface. Such wounds are often associated with patients with diabetes or other vascular disease, or in those wounds that become contaminated and the surgeon doesn't want to close right away. So this is a visual representation of what that primary intention is. We have the clean wound that occurs, and then it's brought together, approximated, and closed, and then your primary intention healing takes place. There's little scarring, and again, this is going to be seen in your clean surgical incisions. The next is your secondary intention. So the wound is gaping or irregular, or is unable to be closed. We allow it to heal by that secondary intention, which occurs when the wound has that extensive tissue loss, which prevents our edges from being approximated, or it should not be closed because it's infected. Because the wound is left open, it heals from the inner layer of the surface by filling in with a beefy red granulation tissue. And granulation tissue is a form of connective tissue with an abundant blood supply, giving it that beefy red appearance. Wounds that heal by secondary intention, again, will heal more slowly. These are more prone to infection, and they develop more scar tissue. Common examples of this would be a pressure injury, or infected wounds, or when a surgeon leaves a wound open to close because, again, it's infected. And then we have our tertiary intention. So tertiary intention is a wound that heals by this delayed primary closure, which occurs when two surfaces of the granulation tissue are then brought together. So we have our open wound, we allow the granulation to occur, and then we pull those two big beefy red granulation areas together. Initially, the wound is allowed to heal by that secondary intention, and then when there's no evidence of edema, infection, or foreign matter, the wound edges are brought together, and then they're sutured in that surface. These wounds require a strict aseptic technique during all dressing changes, because again, they started as healing by that secondary intention, which are at an increased risk for infection. Tertiary intention healing creates less scarring than secondary, but it will have more scarring than primary. Now we're going to go into our phases of wound healing. So the classification of a wound is important in selecting an appropriate treatment regimen and in educating patients on ways to better heal. And our actual phases of wound healing are the same, whether it's a full thickness wound or not, and also regardless of the cause of the wound. We have 3 phases of healing, and those are the inflammatory phase, the proliferation phase, and the maturation phase. So we start with our inflammatory phase, and this typically is about an average of 3 days. This is when the initial injury occurs. We have bleeding, and the bleeding triggers your coagulation cascade, and we have the formation of the clot to stop the bleeding and achieve hemostasis. So little platelets come and clog things up so that we don't keep bleeding out. This process is important because it's a way of preventing blood loss. And it's also going to release a numerous growth factors by the platelets involved in the clot formation. These growth factors, along with your cytokines, which are released during the inflammation phase, play an important role in wound healing. During the inflammation phase, there is an acute increased pain, redness, warmth, and swelling in the injured area as the blood vessels dilate and leak fluid to the tissue surrounding the injury. At that time, your macrophages and neutrophils are drawn to the site and begin the process of cleaning the wound, bacteria, and debris. At the end of this phase, the wound bed is clean and ready to be repaired, which happens in the next phase. Your key points here in this inflammatory phase is to know that hemostasis occurs from your white blood, from your platelets, and that your macrophages and neutrophils will create inflammation because the white blood cells are sent. Okay, so you have platelets and white blood cells at work here. Now we have our proliferation phase, okay, and this is your repairing. We're going to start to fill the wound bed with our granulation tissue, and we're going to have resurfacing of the wound. The phase usually lasts several weeks, 5 to 21 days. It can be shorter with a surgically closed wound, somebody that's healing by primary intention, or it can be significantly longer if the wound is large and left to heal by secondary intention. Next, we have our maturation phase. This is also known as the remodeling phase and can last up to a year. During this time, your collagen continues to be deposited and remodeled. Scar tissue is formed and strengthened. Scar tissue is avascular mass of collagen that gives strength to repair the wound. However, the strength of the scar is never equal to that of unwound tissue, and it achieves only about 80% of the previous strength. So factors affecting your wound's ability to heal. One main factor would be your perfusion, right? So all cells in the body need oxygen to function properly. Specifically, chronic tissue hypoxia is associated with the reduction in collagen formation and a decrease in the action and proliferation of fibroblasts, a reduction in leukocytes, and an impairment of the cell's ability to migrate. Any condition that affects the body's ability to perfuse the tissue with adequate amount of oxygen will adversely affect wound healing. Therefore, our comorbid diseases, such as heart disease, peripheral vascular disease, and pulmonary disease, can lead to prolongation of the healing process. We also have smoking. Even before lung damage has occurred, it's a huge risk to successful wound healing. Smoking impairs the hemoglobin's ability to carry oxygen. The nicotine in cigarettes causes vasoconstriction and increases coagulability of the blood, reducing the blood's ability to circulate oxygen. Diabetes. The impact of diabetes on wound healing is a significant factor to consider in assessing a patient with a wound. Diabetes causes changes in microvascular and macrovascular systems, leading to thickening of the vessel wall and occlusion of the blood vessel with a decreased supply of needed nutrients and oxygen. For a patient with diabetes, the presence of a wound is accompanied by a reduction in collagen synthesis, a decrease in the strength of the collagen, impaired functioning of leukocytes, and a reduction in a number of action of macrophages. Nutrition, we talked about nutrition before and how important it is. If your patient has inadequate nutrition, it will inhibit their wound healing because nutrition is essential for wound healing. With an injury, including any surgical procedure, the body requires additional energy to recover and heal. Although the overall caloric needs increase, sometimes by more than 100%, depending on the severity of the injury, the need for protein increases disproportionately. Protein is needed by the fibroblasts, the process of synthesizing collagen. In addition, deficiencies in vitamin C and A and trace minerals like the zinc and copper have been found to significantly impact on wound healing. Many patients enter the healthcare system in a malnourished state. Others become depleted nutritionally because of the illness, surgery, or medical treatments. An adequate ongoing assessment for patient nutritional status is an essential component of your overall planning for wound healing. Although an older person can heal from wounds, the aging process affects all phases of wound healing. With increasing age, the entire inflammatory response is decreased or delayed. The action of macrophages and fibroblasts is reduced, resulting in decrease in collagen synthesis and slowing of epithelialization of the wound. Due to these physiological factors, in addition to the increased frequency of comorbid conditions, the elderly patient is at higher risk for poor outcomes related to wound healing. Now we're going to move on to our complications of our wound healing. So complications of wound healing, right? That first phase where we're supposed to have hemostasis, we do not, we have hemorrhage. Hemorrhage is greatest in the first 24 to 48 hours following surgery or injury. Swelling of the affected body part, pain, and changes in vital signs, which would be a decrease in blood pressure and an increase in heart rate, may indicate internal bleeding, and we would see a hematoma, which would be a red-blue collection of blood under the skin, which forms as a result of bleeding that cannot escape to the surface. An external hemorrhage is easy to recognize. You'll see bloody drainage from the dressing. However, depending on where the wound is and how the blood flows, it might pool underneath the dressing in an area where we're not able to see. Next, we have infection. So infection causes a delay in wound healing and is a complication of impaired wound healing. A wound that's left open or is contaminated is at a higher risk of an invasion of additional pathogens. Our signs of an infection would be localized swelling, redness, heat, pain, fever, foul smelling, or purulent drainage. Once a wound's infected, the infection causes a prolongation of the inflammatory phase, delays collagen synthesis, prevents epithelialization, and can lead to additional tissue destruction. Infection contributes to a failure of wound to progress through the normal phases of healing and to the development of chronic wounds. Dehiscence, which occurs in connection with surgical incisions, is a partial or complete separation of the tissue layers during the healing process. Evisceration is the total separation of the tissue layers, allowing the protrusion of organs through the skin. People at risk for these complications are the same patients who are at risk for delayed or impaired wound healing. In addition, coughing, vomiting, or straining puts additional stress on healing tissue, increasing the risk for dehiscence and evisceration. These complications typically occur between days 5 and 9 after the surgeries and are related to delayed in collagen synthesis. If a wound is healing properly, a 1 centimeter ridge or an area of induration can be palpated next to the incision line. This ridge is indicative of new collagen being laid down in the wound. If this healing ridge is not felt, the wound's at an increased risk for dehiscence and evisceration. Symptoms include a popping sensation accompanied by an increase in drainage from the wound. Nursing interventions include teaching the patient to splint the incision with a pillow or fold a blanket, or to use an abdominal binder for comfort while coughing and deep breathing and during movement. If dehiscence or evisceration occurs, we need to cover the wound with gauze moistened sterile saline. That should be, the gauze should be sterile as well as the saline, and we need to notify the physician immediately. We have our fistula formation. So a fistula is an abnormal connection between two internal organs or between an internal organ and through the skin and the outside of the body. The organs involved can be identified by the name of the fistula. For example, an enterovaginal fistula involves an opening between the intestinal entero and the vagina, allowing intestinal content to drain into the vaginal area. Fistulas usually are a result of a specific disease process, such as certain cancers and Crohn's disease. Treatment modalities, such as radiation, or any of the factors implicated in poor wound healing. Fistulas predispose the affected person to fluid and electrolyte loss, nutritional deficits, and alterations in skin integrity. This is particularly true in fistula is draining material that is naturally destructive to the skin surface. For example, exposure of digestive enzymes normally found in fluids from the small intestine or pancreas can cause extensive damage to skin in a short period of time. So the first one we're going to look at is an abrasion. An abrasion is a superficial layer of skin. It's usually unintentional, but it may be performed intentionally for our cosmetic purposes to like smooth the surface of the skin. And we have our abscess. This is a localized collection of pus resulting from an invasion of bacterium or other pathogens. It needs to be opened and drained to heal. Contusion, also known as ecchymosis. This is your closed wound that's caused by blunt trauma, and it may be referred to as a bruise or an ecchymotic area or ecchymosis or contusion. Crushing. This is a wound caused by force leading to compression or disruption of tissue, often associated with fracture. Usually there is minimal or there can be no breakage to the skin with fractures. Excoriation, this is a superficial wound. It's usually self-inflicted due to excessive scratching or due to mechanical force. So as the little image is there, the friction can cause the excoriation. Incision, this is an open, it's intentional wound and it's caused by a sharp instrument. Laceration, so the skin or the mucous membranes are torn open, resulting in a wound with jagged margins. Penetration is an open wound in which the agent causing the wound lodges into the body. Puncture, which is an open wound caused by a sharp object. Often there's a collapse of tissue around the entry point, making the wound prone to infection. And then tunneling, which is a wound with an entrance and exit site. Next, we're going to go into our chronic wounds. So chronic wounds are those that exceed the expected length of recovery, usually because of natural healing progression has been interrupted or stalled because of infection, continued trauma, ischemia, or edema. Chronic wounds include your pressure ulcers, your arterial, venous, and diabetic ulcers. These wounds are frequently colonized with several types of bacteria, and healing is slow because the underlying disease process. Unless the type of wound is properly diagnosed, the underlying disease process we need to know for treatment. And many of these can linger for months to years. So our pressure injury, right? This is caused by pressure, shear, and friction, resulting in tissue ischemia and injury. We want to note the appearance because the appearance depends on the stage of the tissue and layers involved. We need the pressure injury tends to be located over our bony prominences. So that's where you're going to want to assess for these. And these can lead to very serious damage. So your stage 1 is characterized by an intact, non-blistered skin with non-blanchable erythema, which would be redness, and the persistence of redness in the area that's been exposed to pressure. Your stage 2, this is partial thickness wound that involves the epidermis and or the dermis, but does not extend below the level of the dermis. This is a stage 2 pressure injury. It's a shallow, superficial, pink wound bed. It has intact or ruptured blisters, and it's the result of pressure. Our stage 3 pressure injuries are full thickness wounds that extend into the subcutaneous tissue, but do not extend through the fascia. So this is not going through your muscle, your bone, or your connective tissue. There may be undermining or tunneling present in the wound. Undermining is an area of tissue loss present under the intact skin, usually along the edges of the wound, forming a lip around the wound, or a tunnel, sinus tract, is similar to undermining, but it's narrow passageway extending outward from the edge of the wound. Although stage 3 pressure injury is described as a deeper wound than a stage 2 injury, the degree of depth is dependent on the location of the wound and the amount of subcutaneous present. For an example, far less subcutaneous tissue is present on the heel or the back of the head than on your hip or your shoulder. Our stage 4 is another full thickness wound. However, when we get to a stage 4, this wound is deeper than a 3. It's going to involve the exposure of muscle, bone, and connective tissues, your tendons and cartilage. The considerable depth of the wound, particularly if the bone is palpable, makes osteomyelitis or an infection of the bone more likely. Our unstable injury is an obscured full thickness skin and tissue loss. So an unstable pressure injury is a full thickness wound in which the amount of necrotic tissue or eschar in the wound bed makes it impossible to assess the actual depth of the wound and the involvement of underlying structures. If it's suspected that the wound is a stage 3 or 4 based on the location and other characteristics, the wound cannot be staged until the necrotic tissue is removed or debrided. Our deep tissue pressure injuries is a persistent, non-blanchable, deep red, maroon, or purple discoloration. When we see this is a susceptible deep tissue pressure injury. This classification was added in 2007. It's an area of intact skin that's like purple or maroon, or it can have a blood-filled blister, like a stage 1 pressure injury. But these deep tissue pressure injuries are often difficult to detect, especially in our darker skin patients. The true depth of the tissue damage is not readily apparent on the initial inspection. These injuries can progress rapidly, exposing deeper layers of tissue, even if treated quickly and appropriately. Then we move on to our arterial ulcers. So this is an image of an ischemic arterial leg ulcer with a deep punch-out appearance caused by inadequate circulation of oxygenated blood to the tissue, which leads to tissue ischemia and damage. These commonly occur on the lower part of the leg, especially the ankles, toes, side of the foot, and the shin. These appear punched out, small and round with smooth borders. The wound base is usually pale with or without necrotic tissue. Surrounding skin appears shiny, thin, and dry, and is going to be cool to the touch. They're going to have loss of hair in the surrounding area, and they have delayed capillary refill time in that area as well. These are very painful, especially at night, and they worsen in pain with increased activity. Next, we have our venous stasis ulcers. These are caused by incompetent venous valves or deep vein obstruction or inadequate calf muscle function, resulting in venous pooling, edema, and impaired microcirculation of the skin. They're usually located around the inner ankle or in the lower part of the calf. Surrounding skin is reddened or brown and edematous. They're usually shallow. They have irregular wound margins. The wound bed appears ruddy or beefy and granular. Drainage may be moderate to heavy, depending on the amount of edema that's associated with it. Pain usually occurs with the leg dependent and during dressing changes. Then we have our diabetic foot ulcers. So due to the narrowing of arteries that occurs during diabetes, that leads to the reduced oxygenation to the feet. This results in the delayed wound healing and tissue necrosis. These are often painless, and we have drainage, swelling, redness. It occurs primarily on your plantar surface of the toes, the ball of the foot, or the underside. And it's highly susceptible to becoming infected because of the poor sensation, poor circulation, and lowered immune protection that these patients have. And we're going to do care and treatments in another video because I have to start a lab now. So I'm going to end this now, and I will pick it up on a different ground.